Many of you have asked me what this branch palliative medicine can offer. So I am Dr. Divya Sai and currently I'm working as a senior resident at a regional cancer center. So I would like to make this as a series which would be small 10-minute video so that it can answer most of your queries instead of putting everything in a single length. So many have asked questions on what the residency looks like, what kind of a cases that we as postgraduates will get exposed to. Will the residency be hectic? And post residency, what are the job opportunities? How is the job market? What super specialty options are there? How is the income aspects of it? And at the end, would you suggest me to choose this branch? So in this series, we will break down each of it and we will walk through them regarding all of the queries that this branch has, because yet still this branch is emerging. Given the number of seats out of a pool of around 50,000 seats on the national pool, palliative branch has very limited seats, say around 20 MD and 16 DMB seats nationally. So not many are aware of what this branch is offering because it is still an emerging specialty currently. So MD courses have started since 2012 at AIMS and Tata. So right now, over the last 2-3 years, the branches have also opened palliative medicine as a specialty option. So I'm the first batch of DNB student. So I would like to take you through what I have been exposed during my residency and how DNB is like, and whether this branch is the one for you or not, because given the limited number of seats, not many are aware of whether to choose this branch or not. So we will go through them one by one. So let us get into how the PG residency is like. So in first year, you're mostly exposed to your setup could be a single center cancer setting or it could be a multi-specialty hospital. So according to the curriculum, you will be exposed to both onco as well as non-onco. So in the first year, you will primarily focus on the onco patients, ward, outpatient department, inpatient consultations, and then you have hospice and home care. So these will be your primary chunk in the first 12 months. In the next 12 months, that is in your second year, you will have a peripheral posting of 3 months of general medicine, and you have certain days for a month of medical oncology, surgical oncology, radiation, and then you have physiotherapy posting, then you have cardiology, neurology, nephrology, and radiology. So all of these super specialty branches are also there in the second year part of the posting, and it is included in the curriculum. And you also will get exposed to interventional pain also in the second year. So it's mostly like we palliative doctors are not completely trained in interventional, but we understand and we can assess the consultant or the doctor, whoever is there. If your center also permits an interventional procedure, you are allowed to do it, or else most of the times you get to see the interventional procedures as well. So you will have to do a separate fellowship to do interventional pain management, because at the end it always requires a hands-on exposure. So it is not just you giving a block, it is also you managing its effects later. So for that particular thing, let us keep it aside. And then in the final year, you do have your, if it is your DNB, you will have exam a little early. So you have to work on your thesis, academic work, and then you will have your theory exams. Once you clear the theory, you're eligible for the practical. So by the end of 3 years, you are done with the entire course, and the third year, mostly again, you will be back to your original primary place. So in the first year, the residency is the residency hectic? Yes, residency is hectic like any other branch. So provided your branch is hectic, it means you have equal opportunities to learn. So if the branch is not hectic there, it means it's just a chill branch. Palliative is not chill. Palliative medicine has a lot of medicine and palliation aspects added to it. So that is palliative medicine. And secondly, you do have night duties. This question is about the night duties. You do have night duties, but it's not as hectic like how your general medicine or general surgery colleagues have that. But you will have it a little bit lighter side. At least you get to sleep around 4 to 5 hours overnight.
It's on an on-call basis. Whenever you get a call, you get up and go, and then you have to monitor your ward patients. And if you have narcotic infusions elsewhere in other wards, you will have to go back and monitor, check those patients on. Then night duties, we will have once in like 5-6 days. You have one night duty, you have Sunday duties. So in the first year you will have around 6 duties, 6 to 7 duties occasionally, and in second year it comes down to 5, and finally you have around 4 duties, 3 to 4 duties. So night duties are hectic. Why? Because palliative care does come with emergencies. These are breathlessness, especially refractory breathlessness. And then another worst emergency is cancer pains. So cancer pains are not like you give a tablet, it subsides. No, cancer pains have breakthrough pains. So they are erratic, they do spike up, and patient do present with acute breakthrough pain episodes which is not being controlled on their regular narcotic dose. So you as a palliative doctor are not just trying to alleviate their pain. It is always like a multidisciplinary management starting from your residency. So you have an interdisciplinary team meeting with physiotherapist, with your nursing staff, with your social worker, and then you have your community workers, and then you have the dietetic team. So it's like so many people are there, and all of you are working towards a single goal of improving the quality of life of patient. So the kind of patient that you tend to see are not just someone who is dying. Palliative care is not respite care. Palliative care is not for someone who is only dying. Palliative care is not for someone who is at end of life. So you tend to see different cases, be it hematology cases, be it transplant patients, be it your patients who are ongoing their chemotherapy, patients who are ongoing radiation therapy, pediatric patients. These are all pertaining if you are in a cancer setting. Say suppose you are in a multicentric setting. You have patients with referrals from the ICU care, wherein you have to talk about advanced care planning, extubation in case if it is needed. Then you will talk about advanced, living well, if they have a living will, understanding what their medical directives are, and then trying to resolve complex family situations, having difficult conversations with family. And it is not just physical symptom, but also psychological symptoms, both not just for the patient but also for the family members. And then you have patients who are ongoing dialysis, and you get referrals for symptom management during dialysis. Patients with chronic heart diseases, these are usually seen in your multicentric study. But if you are in a single setting onco, these are the different conditions that you tend to see. And then how is the OPD like? So the OPD is like you tend to see around 30 to 50-60 patients a day, because beyond that it is also not possible to see, because OPDs usually are a little longer. They maybe you can consider as a per person OPD time is around 5 to 10 minutes time. Some patients would require much more attention or much more examination in detail, or trying to they emotionally break down, especially if you're in a cancer setting. So trying to provide adequate support when needed is equally important. And then some hospitals also do have a immediate procedure room next to the outpatient department to manage acute pains, wound care management, or tracheostomy cares, stomach cares. All of them are managed in the procedure room that is just right next to the OPD. And many things that are needed, like a Rajshri placement or a cytic tapping, everything is done in the procedure room. And ward may you have around, depending on the type of institute, you have around 7 to 10 to 15 beds. Some also have around 20 beds. And then you have inpatient consultations, wherein the patients are being admitted under the treating physician, be it your medical oncologist or radiation oncologist. So you tend to see patients who are admitted under them in when they have come for their checkup, or when they are in their supportive care under them. So you also have inpatient consultations. And then you have casualty calls, that too mostly for pain management, patients who have come with refractory breathlessness, patients who have come with gasping. So trying to set that environment, have that goals of care discussion is something that we tend to do in residency. And residency is not going to be easy, because this is the first time that we as students are getting exposed to something that is totally new. We have never seen patients like this, because back then in our internship, casualty is somewhere we have seen patients die. So it is not very common, and death is not seen as success. in general medicine. I always aspired to take up general medicine, but I understood what my priorities were, what my goals were, and the kind of care that I wanted to give my patients. So I have taken palliative by choice, and it is very fulfilling because you're not just treating patient with medicine, but every case will teach you more than just medicine. It teaches you a lesson, it teaches you a lot of empathy, a lot of, the way you approach a patient, the way you communicate. You're trained in advanced communication skills, breaking bad news,